So good morning everyone. So malaria 2, it will include the diagnosis of malaria. So malaria, it should be recognized promptly in order to treat the patient in time and to prevent further spread of infection in the community. Because the cause of death, the major cause of death in the malaria patients is usually a delay in diagnosis and treatment of the patient. Okay, so whenever there's a suspicion of malaria clinically, it should be confirmed with the laboratory. So regarding the diagnosis, there will be a clinical examination, a clinical suspicion, okay, as a result of history taking and physical examination. Then when you send to the laboratory, there will be different categories by which malaria can be, the parasite can be identified. It can, the majority we use means in the most of the cases, most of the time we use a microscopy. So most of the time we use the microscopic technique of diagnosis, and under the microscopic technique we have the peripheral blood smear, we may have the fluorescent microscope, we can use a fluorescent microscope for the detection of the malarial parasites, okay. And other modalities of diagnosis will be antigen detection. It can also be detected through culture. However, culture is usually done for research purposes, not particularly for diagnosis of the malarial parasite, and a molecular diagnosis can also be done. So peripheral blood smear, okay, first under microscopy there are two categories. One you can do using the blood smear, which is a simple type and it's cost effective, okay, it's not very expensive. So you can do the blood smear or you can go in for a fluorescent microscope, okay. But in a case of a peripheral blood smear, okay, it is simple, it is very simple, it is a gold standard. Gold standard means once you find a parasite in a peripheral blood smear, that is definitely a confirmatory test. You do not have to go in for other modalities of testing, okay. So what is a specimen which you would collect for a peripheral blood smear? It can be from peripheral blood, either from the earlobe or the finger prick. Finger prick is usually the sample which is taken, okay, because you want, means only from the capillary areas, okay, the capillary regions like the earlobe, the finger prick or the grade 2 in case of infants. And when is the best time for taking the blood? It will be a few hours after the peak of fever and before taking any anti-malarial drugs. And the frequency of smears, it's a single smear, it is not sufficient, okay. So this at least twice daily it should be examined. A smear should be examined at least twice daily until the parasites are detected. This is for a very strong suspicion. When there's a strong suspicion that a patient is suffering from malaria, you can take the blood from that particular patient. If you do not get in the first smear, you ask for a repeat sample. So at least you should examine the smear of that particular patient at least twice a day. So there are different types of peripheral blood smear. They can be a thick smear, it can be a thin blood smear. These should be prepared and read immediately by the experienced personnel. I think you've already experienced preparation of a thin blood smear, okay. So a thick smear is usually to detect parasites. A thick smear is to detect parasites because it means it has got a high sensitivity, because we need a larger amount of blood for making a thick smear. Whereas a thin smear, it's usually for categorizing the different species. Like for example, ma'am has already taken the class on the different species of Plasmodium parasite which causes malaria, okay. Plasmodium, falciparum, Plasmodium, vivax, Plasmodium, ovale, Plasmodium malaria, and Plasmodium knowlesi. So these species can be differentiated only by using a thin smear, okay. This species differentiation cannot be done when you examine a thick smear. So thin smear, how do you prepare a thin smear? A drop of blood is taken on one end of a clean glass slide, and the blood is spread evenly and thinly with the help of a spreader. So you can see here the blood is usually spread, the smear of blood is usually placed here, and then by means of a spreader it's usually pushed, okay, to the other end of the slide until there's a feathered end which should be at least 2 centimeters long. So the film is dried and stained. Okay, this is how you prepare. This is when the using another glass slide as a spreader. Okay, that blood smear is prepared. Whereas a thick film is prepared by taking 2 to 3 drops of blood. Okay, they are placed on the slide, and with one corner of another slide, a circular or square patch of about 10 millimeters or 1 centimeter is made. Okay, this is it, right? And another additional step when you prepare a thick film is this dehemoglobinization. Okay, what do you do? How do you do this dehemoglobinization? It is very simple. You just place that prepared film, that dried film, in distilled water in a glass cylinder. Keep it in a vertical position. The glass cylinders are vertical. Okay, you must have seen many such glass cylinders in the pathology laboratory. Okay, you place this thick film and immerse it in distilled water for approximately 5 to 10 minutes. This film is then dried and then steamed. So this is how preparation of the thick film is done. Okay. So the staining is usually done by using Romanovsky stain. Okay, Romanovsky stain can be Leishman stain, it can be JSB stain, that is just one Singh and Bhattacharya stain, or it can be Leishman stain. Okay, so all these stains they are categorized under Romanovsky stain. Okay, so when you examine these slides, you have to remember, okay, when you examine a thin smear, Plasmodium vivax, ovale and malaria, all the asexual erythrocytic stages as well as the gametocytes are seen. Okay, so when you examine a thin peripheral smear, okay, if that infection is due to Plasmodium vivax, Plasmodium and ovale or Plasmodium malaria, then all the asexual erythrocytic stages as well as the gametocytes can be seen. But in case of examining of a smear, of a thin peripheral smear of a patient having Plasmodium falciparum, you can expect to see only the ring forms and the gametocytes. Okay, because the other stages, the later stages of the erythrocytic cycle in case of Plasmodium falciparum, they usually takes place in the capillaries of the internal organs. So they are not circulating in the peripheral blood except for very, very severe infections. Okay, then you can see some late erythrocytic stages which can be seen in the blood. Okay, so these are the different types. Just to, I think ma'am has already shown this slide. Okay, just to go through the different types of the stages of the parasite. There's an early trophozoite stage, late trophozoite, schizon stage, a female the gametocyte stage which can be male or the female. Okay, so in case of Plasmodium vivax, you can see this is the early trophozoite. You can see this is the Plasmodium species. Okay, it has got a vacuole and the cytoplasm. This blue thing is a cytoplasm which is pushed, okay, as a result of that vacuole, and there's a nucleus. So it looks like a ring. Okay. So what is particular about this Plasmodium vivax is that you can see here the RBCs as compared to these RBCs, they are bigger. Means the parasitized RBCs are bigger in case of Plasmodium vivax. Okay, this is because in Plasmodium vivax, they can infect even the young RBCs, okay, which are larger in size, and hence the parasitized RBCs will be larger. Okay, whereas in Plasmodium falciparum, malaria, ovale, you can see ring forms are definitely there. Okay, but in case what is particular again about falciparum is that, see, there may be multiple ring forms which are present in one RBCs. Okay, there's also, you can see this formation is also there. This is the Acoli form, okay, where the nucleus is projecting out through the plasma membrane of the, it's projecting out through the membrane of the RBCs. Okay, so you can see such forms are there in Plasmodium falciparum. Okay, Plasmodium malaria, ovale, the ring forms are similarly to Plasmodium vivax. Now the late trophozoite forms are seen. So you have to remember that in case of Plasmodium falciparum, only this form, that is the early trophozoite form, and the gametocyte form they can be seen in the peripheral blood smear. Okay, these forms like the late trophozoite and the schizone form will not be seen because the late stages, I told you, in the later stages of the erythrocytic cycle, in case of Plasmodium falciparum, will take place in the capillaries of the internal organs, but it is not so with the other species. Okay, so in case of when you look at the peripheral blood smear, in case of vivax, you can see these amoeboid forms. Okay, these amoeboid forms, this parasite tends to move at this stage. Okay, it is irregularly, irregular. Okay, whereas in case of malaria, you can see these are band forms which can be seen, which are very characteristic of P. malaria. And but similarly, this Plasmodium knowlesi can also produce such band forms. That's why it gets confused with this Plasmodium malaria. Okay. Whereas in case of Plasmodium ovale, look at the parasite. Okay, look at the RBC. The RBC, it becomes oval in shape, and there's a feathered end. Okay, you can see all these ends. They are feathered. Understand? So these are some particular characteristics of the different species of the parasite. Okay. So but similarly, if you look at Plasmodium falciparum, the gametocytes, they are banana shaped gametocytes. Okay, whereas in the others, they are circular shaped gametocytes. Okay, so these are the characteristics of the different species. So you can see here again, okay, this is the actual picture following a staining of the peripheral blood smear. In case of Plasmodium falciparum, you will be seeing the ring form and you will be seeing the gametocytes. Okay, so parasitized red cells, they are not enlarged. Why they are not enlarged? Because they affect the mature RBCs. This Plasmodium falciparum species will infect the mature RBCs. Okay, so in case of Plasmodium vivax, you can see all these 4 stages. You may see the ring forms. Okay, you may see the trophozoite form, the schizone forms, as well as the gametocytes. So here the parasites of Plasmodium vivax, they prefer young red cells. Hence, you can see this parasitized RBCs is enlarged. Okay, because they affect the young cells which are larger in size as compared to the mature cells. Okay, in case of Plasmodium malaria, again you can see the trophozoite form, it is band forms are seen in case of Plasmodium malaria. Okay, in case of Plasmodium ovale, I told you the parasitized RBCs, they are oval in shape and they have tufted ends or striations at one end. Okay, and in case of Plasmodium knowlesi also, the parasitized RBCs are not enlarged. Okay, the trophozoite, the pigment may spread. You can see there are certain pigments which may spread inside the cytoplasm like the Plasmodium malaria. But here there's multiple invasion. These others, a single parasite is invading a single RBCs, except for Plasmodium falciparum, where multiple parasites can invade a single RBC. But in case of Plasmodium knowlesi, okay, the other features are similar to the Plasmodium malaria, but they can also invade. Multiple parasites can invade a single RBC. Okay, and the level of parasitemia is also high. Okay, the level of parasite circulating in the blood may be high, but all stages are present in peripheral blood. Okay, in case of Plasmodium, just see these forms. Okay, these forms, these are head forms. You can see, so they may present like that. Multiple parasites are infecting a single RBCs. A coliform can be seen in case of Plasmodium falciparum. And these gametocytes, the characteristic is that they are cigar shaped or banana shaped in banana shaped in just by looking at it. So you can distinguish this species with the other gametocytes. Okay, in vivax also, for example, single RBC is infected with a single parasite, and look here, Okay, you can see that the cytoplasm, which is opposite the nucleus, it's thicker. Okay, that is another feature of this Plasmodium vivax as compared to Plasmodium falciparum. Okay, so here you can see the amoeboid form or the late trophozoite stage of the parasites. Okay, here you can see the schizons, okay, which contains these merozoites. These are merozoites. Okay, the structures are the merozoites, and these are the gametocytes of the Plasmodium. Plasmodium ovale, as I told you, they have characteristic, the parasitized RBCs have a characteristic oval. So next, after the peripheral blood smear, okay, there's another method which is known as this quantitative Buffy coat, okay, for examination of this the parasites of which cause malaria. Okay, this can be done by first concentration of blood by centrifugation. So you will take here a capillary tube is usually taken. Okay, this capillary tube is lined by acridine orange. Okay, it's lined by acridine orange. Okay, then you take blood inside the capillary tube, then you centrifuge that capillary tube, and then you'll examine under ultraviolet light. Okay, so here the principle of the test is that this acridine orange stain, okay, this acridine orange stain, it stains the nucleus. It stains any nucleus and produces a fluorescent brilliant green color of the nucleus. Okay, so when you think about normal RBCs do not take up this acridine orange stain because they do not have any nucleus. But in case of parasitized RBCs, this acridine orange will stain the nucleus of the parasites which are inside the RBCs, and hence those parasitized RBCs will appear as brilliant green dots. Okay. However, WBCs can also take up the stain since they also have nucleus. Okay. Look here. So after centrifugation, you'll find that this is a capillary tube. Okay, this is a capillary tube having the layer of acridine orange, okay, which is lined with acridine orange, and after centrifugation of this particular tube, the components of the blood are divided into different parts. Okay, so you can see here in the bottom, depending on the density, okay, depending on the density, the components of the that blood will be separated. Okay, so you'll see here, for example, you can see here, this is a thick layer of red blood cells, okay, and this is a thin layer of red blood cells. So you can see that, okay, you can see in between the granulocyte layer and the thick layer, they are the parasitized RBCs will be found here. These are the parasitized RBCs. Okay, then there will be the granulocyte layer, eosinophil, mature forms. Okay, mature asexual forms may be found here. Okay, like the gametocytes of even the gametocytes of Plasmodium falciparum will be found in this layer, somewhere in between the lymphocyte layer and the granulocyte layer. Okay, then above that there will be this platelet layer. Okay, and so this tube, okay, this tube is usually examined using a fluorescent microscope. Okay, where they will see the brilliant green dots. If at this part, okay, at this part they'll see the brilliant green dots at this part. Okay, so here you can see, okay, it will appear somewhat, okay, like this. It's not very, means it needs expertise, so it's difficult to perform. We don't usually do this test, okay, because the gold standard is still the peripheral blood smear. Okay, but nowadays we going in for rapid diagnostic tests as well. Okay, so for a rapid diagnosis, okay, so that you can at least give the patient, means some therapy can be given to the patient, okay, before you send a peripheral blood smear. Okay, so here what are the antigens which are targeted? Okay, the antigens will be the HRP, that is the histidine rich protein 2, okay, the parasite lactase dehydrogenase, okay, and the aldolase. Okay, these are the three enzymes which are particularly targeted in the rapid diagnostic test. But if you see here, in case of the Plasmodium falciparum, okay, so you can utilize for detection of Plasmodium falciparum, you can use Plasmodium falciparum produces this HRP2, okay, histidine rich protein 2, which are not produced by the other parasites. Okay, so this test can be used for Plasmodium falciparum, this rapid test. Okay, whereas in case of the other test, Plasmodium vivax, you can do a parasite, LDH, okay, the lactate dehydrogenase can be produced by all the species of all the Plasmodium species. Okay, so you can use a pan lactate dehydrogenase test for detection of the species. Okay, and the aldolase test, similarly the aldolase test is produced by all the species, so you can try to use this rapid test for diagnosis, for just to give you an idea whether these species are actually present in the blood. Okay, but this, just remember that the HRP2 is only produced by Plasmodium falciparum, whereas if you were to speciate Plasmodium vivax, malaria, ovale, you will not be able to speciate. Okay, understand, because there are no tests which are available, okay, to speciate these parasites, okay, the species of the parasites. Okay, so this is a rapid examples just to show you how the rapid diagnostic test look like. You can see in the medicine department they are using these tests. Okay, so some companies like Parasite F, okay, immunochromatographic test malaria, Plasmodium falciparum. This one, it detects the histidine rich protein HRP2, okay, of the Plasmodium falciparum. So sensitivity, it can be 77% to 100%. It has got a specificity of 83% to 100%, but it has got its limitations also. Okay, this is a rapid diagnostic test, this optimal test. It detects the Plasmodium lactate dehydrogenase. Okay, so here lactate dehydrogenase can be usually this test is available, the PAN LDH. Okay, so if there's a strong suspicion, they go in for this one, HRP2, no, just to see if Plasmodium falciparum is there or not. Okay, but there's a certain LDH which targets only Plasmodium falciparum, means such test can also be available in the market. So this is Plasmodium lactate dehydrogenase. An advantage of this test over the HRP2 test is, number one is that, I've told you, the HRP2, you can only detect Plasmodium falciparum. Okay, but this particular enzyme, this HRP2, or this particular enzyme or antigen, it will be present. Okay, it will be present even after a therapeutic response. For example, if you give anti-malarial drugs to the patient has responded, but even after the patient gets better, that HRP2 will remain in the blood of the patient. Okay, but in this case, in this enzyme, this lactate dehydrogenase, it will not. It will disappear once the patient gets better. So this is actually, okay, if you want to know the prognosis of the patient, if you want to know whether the patient is responding to the drugs which are given, then you can go in for testing of this Plasmodium lactate dehydrogenase. Okay, so what are the advantages and disadvantages of rapid diagnostic test? The advantages are that it is simple to perform. It can be used in the field for detection of malaria. It is rapid, okay, and it is easy to carry, okay, to transport. It does not require electricity. It does not require microscopes. Okay, so it is 90% sensitive and can detect 100 parasites per microliter of blood. Okay, it can detect 100 parasites per microliter of blood. And this parasite LDH, as I've told you, it's produced only by viable parasites. Hence, it is very, very useful to monitor the response to the treatment. Okay, whereas HRP2 is a reliable marker to diagnose malaria in pregnancy. This is only in case of Plasmodium falciparum. Disadvantage, it is more expensive. It cannot differentiate between the non-falciparum species. Okay, as I've told you, this parasite, it cannot differentiate with non-falciparum because only that aldolase and the parasite LDH can be used, okay, which cannot actually differentiate between the non-Plasmodium malaria species. Okay, false positive test, okay, false positive result may be seen in a case of rheumatoid arthritis. Okay, lower limit to detect is 100 parasites per microliter for LDH, and for HRP2 is 40 parasites per microliter. Okay, so it's very limiting. Okay, and in case of, because in case of blood film, okay, when you prepare thick blood film, okay, you can detect, okay, when the parasite is approximately 5 to 10 parasites per microliter, you can detect the parasites, okay, you by looking at a thick blood film. Okay, but here the lower limit is up to 40 in case of HRP2, but 100 parasites in case of LDH. Okay, and in case of HRP2 and HRP3 gene deletion, it can result in a false negative Plasmodium falciparum result. So there are different molecular methods also apart from the microscopy, the rapid diagnostic test, okay, quantitative Buffy coat. There are molecular methods such as a PCR method can be used for detection of certain genes for 18S ribosomal DNA. Okay, LAMP can also be used, that is loop mediated amplification technique, and MASBA, nucleic acid sequence based amplification. And detection limit is usually lesser than 5 parasites per microliter, and it can be used. This is molecular methods are actually useful for detection of drug resistant genes. Okay, not particularly for diagnosis of malaria, but you can utilize this molecular method, you can utilize a PCR if there's a chance of, means if there's a suspicion of a drug resistant malaria. Okay, so what are the things, what are the anti-malarial strategies? Okay, what the anti means, how do we prevent this malaria infection? So first, okay, what we have to do is, because malaria is caused by vectors, we have to fight the mosquito vectors, okay, by drainage of any swarms, ponds and all which are not necessary, okay, which are harboring these malaria, the vectors of which are causing malaria. Okay, so by the action of larvivorous fish, there are certain fish which actually eats the larva of the mosquitoes, so this will help as an anti-malarial strategy. And insecticides can be used, mosquito nets can be used, and drugs for prophylaxis and therapy. Okay, because vaccination as of now it's not available. So vector controls, you can drain unnecessary water holes, okay, use of larvivorous fish, okay, in rice fields, which can actually ingest these eggs as well as a larva of the mosquitoes, and spray with insecticides. Okay, so DDT is still used as an insecticide. Okay, so what is the treatment? Treatment of vivax malaria according to National Vector-Borne Disease Control Program guidelines in India. Okay, chloroquine 25 milligrams per kg divided over 3 days. That is, you give 10 milligram kg on per kg on day 1 and 2, and 5 milligram per kg on day 3. Okay, and primaquine 0.25 milligram per kg body weight daily for 14 days, but it should be given under supervision. It aims to kill the hypnozoites of Plasmodium vivax to prevent relapse. Ma'am must have taken, no, what do you mean by relapse? What do you mean by recrudescence? I think she must have taken that, means she must have told you regarding all this in the previous class. Okay, can you tell me what is relapse actually? Anybody tell me what is relapse?
When the hypnozoites lead to infection years later.
Okay. Okay, reactivation of the hypnozoites. Where are these hypnozoites found?
In the liver.
In the liver. Okay. Okay, so that is relapse. Whereas recrudescence is as a result of inadequate treatment. Okay, some low level of parasites will remain in the blood, which can cause infection at a later period. Okay, which is seen in case of Plasmodium falciparum. So treatment of falciparum malaria in northeastern states, that is ACTAN, that is, which is co-formulated tablet of artemether and lumefantrine, okay, and as well as primaquine can be given. and other states are ACT-SP, that is artesunate with sulfadoxine and pyrimethamine as well as primacone. Okay. So why is it given in these Plasmodium falciparum in case of northeastern states? It's a bit different as compared to other states. It's because of the chloroquine resistance which is seen in case of Plasmodium falciparum in the northeastern states. So WHO also defined, when we talk about anti-malarial drug resistance, it has a particular definition. It defines it as the ability of a parasite strain to survive or to multiply despite administration and absorption of a drug given in doses equal to or higher than those usually recommended, but within the tolerance of the subject, and the drug must be able to gain access to the parasite. Okay. So how do you diagnose this anti-malarial drug resistance? Okay, by the clinical, if there's the level of resistance which is usually seen clinically when a patient is taking anti-malarial drugs. Okay, usually that patient is usually observed looking at the patient's whether the patient is deteriorating, whether the patient is having fever, looking at the clinical condition of the patient. Okay, that is an in vivo observation. But in case of by the testing, it can be done through maybe trying to grow this parasite. Okay, trying to culture in a media. Okay, which is RPMI 1640. Okay, or using molecular methods. I told you, you can try to find out the drug resistance, whether that person has a drug the person is having resistance to the anti-malarial drugs. Okay, or using other techniques. Okay, so this is when you look at the clinically, how do you look, means how do you observe that treatment failures occurring. Okay, these are the definitions. For example, early treatment failure, it can be severe malaria. There will be a fever on the day 0, okay, to 3 of starting of the anti-malarial drugs, and parasitemia again on day 3, okay, which is even higher than the parasitemia which you observed on the day 0. Okay, so this is the definition of early treatment failure. In case of a late clinical failure, how do they define it? They define it, they look if there's a case of severe malaria or high fever of more than 37.5 degrees centigrade in the presence of parasitemia from the day 4 to the 28 without previous meeting of any criteria of early treatment failure. Okay, so this is a late clinical failure. And a late parasitological failure, there's a term which is known as late parasitological failure, that is presence of parasitemia on any day from the 7th day onwards, okay, up to the 28 days, and the fever is less, okay, fever lesser than 37 without previous meeting any of the criteria of early and late. Okay, and if there's an adequate, okay, but the patient may also be suffering an adequate, may also be experiencing an adequate clinical and parasitological response, that is an absence of parasitemia on day 28. So if you examine the slide again, you'll find that there's no parasites in the slide. Okay, irrespective of fever, without previous meeting of any criteria of early and late treatment failure. Okay, so that will be an adequate parasitological response, because even though there may be fever, but the parasites, there will be no parasites in the peripheral blood smear of the patient. That's why it's known as a adequate clinical and parasitological response. So that is all regarding malaria. Have you understood the diagnosis? Are there any doubts? So what I want you to remember in case of laboratory diagnosis of malaria is that the gold standard is the peripheral blood smear. Okay, there are two types of peripheral blood smear, a thin peripheral blood smear as well as a thick peripheral blood smear. Thick peripheral blood smear, you use a larger amount of capillary blood to make the smear. Okay, it is 40 times more sensitive as compared to your peripheral, the thin blood smear. Okay, But the advantage of the thin blood smear is that you can categorize the different species as a result of examination of the thin blood smear. Okay, whereas a thick blood smear will just be able to tell you that the parasite is there in the patient or not. Okay, the parasite which causes malaria is there in the patient or not. Okay, and it is a very sensitive for detection of the malarial parasites. But a peripheral thin blood smear is the smear we use to differentiate one species of Plasmodium from another species. Okay, so the other methods are the antigen test, the antigen diagnostic test, or the rapid diagnostic test using the different enzymes, okay, such as the HRP, that is histidine rich protein 2, which is produced only by the Plasmodium falciparum. Okay, but the other enzymes such as aldolase and the parasite lactate dehydrogenase, it can be produced by all the species of the parasite. Okay, again, one thing which you definitely have to remember is that in case of HRP2, it can remain even after treatment of the patient. Even after the patient has responded to treatment, HRP2 will be remaining in the blood of the patient. However, the parasite lactate dehydrogenase, since it's produced by viable parasites, okay, it will disappear. Okay, so you can actually see the progress. I mean, you can see the response, if there's any response to the treatment or anything, by looking at the parasite by testing using the parasite lactate dehydrogenase rapid diagnostic test. Okay, so the other modalities of laboratory diagnosis are culture, which can be done for research purposes, and I told you, even to see whether there's a drug resistance or not, and molecular method also. The main use of the molecular method here is to detect the resistance to the anti-malaria. So this one is very short. Okay, babesiosis. Okay, this, it belongs to the same family as this malaria, the Plasmodium. Okay, it is caused by Babesia. This Babesia, which was named after a Romanian scientist, Sir V. Babes. Okay, it is also known as Texas cattle fever, and it is tick-borne. It's caused by the vector, okay, tick, and it is also known, it causes a tick-borne hemolytic disease of the cattle. And the Babesia species which are important in humans are Microti, Babesia divergens, Babesia duncani, and currently an unnamed agent is also there, which is known as MO1. Okay, that is under the Babesia species, which are important as the ones which cause human infection. Okay, the host is the deer tick, Exodus scapularis is a definitive host. Humans are the intermediate host, and the modes of transmission is by the bite of ticks. Okay, so when the tick bites a human, it introduces a stage of the parasite, that is sporozoid stage, into the circulation. During a blood meal, what happens? The sporozoids will enter into the RBCs, where they transform into trophozoites, okay, similarly like malaria only, and then multiply asexually by budding, giving rise to 2 or 4 pear-shaped trophozoites. Okay, so they look like this Maltese cross form, and these are arranged inside the RBCs. I'll show you the picture, okay, in the subsequent slide. Some of the asexual forms also transform into gametocytes. Okay, so this is the cycle in man. Okay, sporozoids will enter, which is introduced by the tick. Okay, it will enter into the RBCs, they transform to trophozoites, and then they have a particular arrangement which is known as the Maltese cross form arrangement. Okay, these trophozoites are arranged inside the RBCs, but some of these trophozoites, they become converted into gametocytes. So following a blood meal, okay, the gametocytes, following a blood meal, the gametocytes are taken up by the tick, and they reach the intestine of the tick, where they multiply sexually and then migrate salivary glands, where they transform into trophozoites. So the life cycle goes on like that. Okay, so trophozoites, they are again introduced into the humans when the tick bites the humans, or the nymph. The nymph means the larval form of the tick. Okay, it's crushed against an abrasion on the human skin. So the pathogenesis and clinical features, incubation period is 1 to 6 weeks. It can be mild or it can be severe. Okay, mild is malaise, fatigue, weakness, fever, chills, okay, some headache, body ache, okay, anorexia, dry cough and arthralgia. And when it is a severe infection, okay, this can happen when the level of parasitemia is more than 4% and manifest in the form of severe anemia, acute respiratory distress syndrome, disseminated intravascular coagulation, congestive heart failure, renal failure, splenic infarcts, as well as rupture of the spleen. So the predisposing factors which can lead to the severe infection are age, old age group, that is more than 50 years of age, patients with splenectomy, HIV, AIDS, malignancy, immunosuppression. And how do you do laboratory diagnosis? Again, using a very simple peripheral blood smear. You can demonstrate. You can see here in this picture. Okay, you can see here. See, these, they look like Plasmodium species, isn't it? When they invade an RBCs, but some of them are arranged in such a way that when they are stained, it looks like this. Okay, when there are 4 rings which have invaded an RBC, okay, it looks like this cross, which is known as a Maltese cross forms. Okay, so you can demonstrate 2 or 4 rings of 1 to 5 micrometer size inside the RBCs, called as Maltese cross forms. And I told you that it can be confused with Plasmodium falciparum because it's actually multiple rings are invading a single RBC. Okay, but it can be differentiated because there will not be pigments as produced during the malaria infection. Also, there won't be the gametophytes. Gametophytes also will not be there. Okay, and the presence of pear-shaped rings. Pear-shaped rings also, it may be present, means elongated or irregular shaped rings may be present when they form this Maltese cross forms. These are not found in case of Plasmodium falciparum. So the treatment for mild cases, atovaquone plus azithromycin for 7 to 10 days, and for severe cases, IV clindamycin plus oral quinine can be given for 7 to 10 days, and blood transfusion can be considered in case of severe anemia cases. Okay, so that is all regarding this malaria.